Prior to my experience with hospice, I thought that it was strictly end-of-life care. I didn't know anything about the other services it provided and the comfort it could bring. I just thought someone would come in and just have a nurse visit you until the end.
My perception about hospice before it was introduced to our family was end-of-life care, that they come in. But I will say probably care wasn't even the word that came into my head. I thought they were an organization that came in and would accelerate the passing when the time was coming, would pretty much, medicate them so that they were comfortable and probably, and that was that. I didn't think there was a whole lot more to it.
It would have been end of life. That's what it would have meant to me. End of treatment, end of life. I would have felt that when you finish your treatment and you're not going to go any farther, then you go over to hospice, which is purely that, end of life. It's bringing you down to the end, getting you through a journey.
Please don't say hospice yet. I would think, no, it's not time yet. Just by fear. It would be fear. It would create fear. It did create fear.
Palliative care is interdisciplinary care for any patient with a chronic life-limiting illness, which focuses on physical symptoms, psychological symptoms, social symptoms, and spiritual symptoms. Palliative care can be provided throughout the duration of an illness through treatments such as chemotherapy or surgery, and brings you right up to the point of requiring or needing end-of-life care, and that's where hospice care comes into play. Hospice care is for patients who have a terminal illness, being defined as a probable prognosis of 6 months or less, with the best guess of the medical team deciding that. And they're also foregoing any curative treatment for their terminal diagnosis. So they're no longer receiving chemotherapy for a cure. They're not going to receive a lot of times, surgery to remove a tumor in hopes that they would be better. It's a Medicare benefit that originated back in the 60s and provides patients with total insurance benefit for their end-of-life care.
One of the things I think that's really important for people to realize when they go on hospice care, as I said earlier, is not about giving up. It's not about the fact that I've chosen hospice and now my days and weeks and months are nearing the end. The most important thing about hospice is to know that we value life and that we value that time that families and patients have together at the end.
Hospice and palliative care is now a recognized specialty. There is a board certification for that, which I've actually gone through and have my board certification. But this is an area that was once sort of an afterthought and now is very much in the forefront. It's really a part of the trajectory of care for pretty much oncology and really all of medicine incorporates palliative care and towards the end hospice. And there's active research. We're learning a great deal as we go. It used to be we sort of just made things up as we went, whatever seemed practical, but we have learned a great deal from research that's being done and how best to manage pain and other symptoms. So this is really a growing specialty.
I think it's a misconception that when you send someone to hospice, there's nothing more to be done. Sometimes I see families and other healthcare personnel say, don't mention the word hospice. Don't bring that up. The patient will be upset. Well, that's because it's not presented correctly. And I think correctly presented, there's an important opportunity to help people that's missed if we don't have this communication.
There is a misconception that when hospice is called in, that the physician is less engaged in the care of the patient, and it's just the opposite. All decisions that hospice personnel make are run by the attending physician. he continues to have complete control of the care of the individual. And I feel as though the care of my patient is enhanced when hospice is there, because it's a direct window into what's going on in the home situation. They're in close contact with me and my office, which is not often the case when hospice is not involved, or there's necessarily a visiting nurse, or just family members. And often a crisis situation arises, which can be avoided when the hospice team is there. So I'm very much involved in the care of the patient when hospice is there, and I welcome them being there, because every decision is run by me. I can contact them and make decisions collectively with them. So in fact, patients are not abandoned. The quality of their care is enhanced.
One of the things that's important for me to keep in mind is that I have patients in a wide variety of residential settings. I have some patients living in their own homes. I have some patients living in assisted living. I have some patients in nursing homes, and also in group homes and in hospitals. Hospice is a tremendous benefit to me and to my patients and to their families in all of those settings. So hospice really is helpful no matter where the patient is, and is a tremendous help to me in the hospital also.
As far as the type of patients that can receive hospice care, it is not only for cancer patients, which is what many people still think after over 30 years of hospice being in the United States. They still feel it's just for cancer patients. Many patients can benefit from hospice care, from cardiac disease, pulmonary disease, advanced dementia and neurological diseases like ALS or Parkinson's disease, and even patients who are elderly and who are just at the end of their life and slowly declining over a period of time.
The other thing that's a misconception about hospice is that we stop medicating the patient, that we take them off the medications that make them comfortable. And that is not at all the case. We actually are really concerned that a patient is comfortable and continues on the same treatment regimen that they had to make them comfortable. If a patient is on our hospice program for a cancer diagnosis, but really they have other medical issues that are causing them to have problems such as they're diabetic, or maybe they have high blood pressure, certainly we would not take them off those medications. We would do whatever's needed to make them comfortable.
The first time I encountered hospice care and became familiar with it was approximately 11 years ago, when my mother, who was 94 at the time, had Alzheimer's dementia. And we made a decision along with her physicians that her care would be best given in the home setting with the expertise of a hospice environment. The first time I used it professionally was approximately 7 years ago in a patient who was elderly, who had end-stage heart failure, and we had run out of options to improve the duration of that patient's life. And we contacted hospice directly within the Danbury community. I think engagement of the hospice team at an earlier point would have improved the quality of both of those patients' lives, at least the last several months of their lives, had we instituted it earlier.
Some of the barriers to providing hospice care to patients is the timing of the referral of a hospice consult. Connecticut has one of the shortest length of stays for patients who choose the hospice benefit in the country, meaning that the caregivers, the physicians, the nurse practitioners, the primary care providers are not comfortable bringing hospice up at the appropriate time during the progression of a patient's disease. Many diseases are uncurable and can't be fixed. For example, heart disease. There's 4 stages of heart disease. At the beginning stage, stage 1 of heart disease, there's minimal symptoms. But by the time they get to stage 4, they have multiple symptoms. And the patient is going to eventually get to stage 4 heart disease. And at that time, the physician or the primary care provider brings up hospice care, and the patients and the families are shocked about that. And what do you mean hospice care? Am I dying now? Whereas if hospice was broached earlier in the progression of their disease, when the time comes and it is appropriate for them to use hospice care, it is not going to come as such a surprise. Another barrier is also how to even bring up that topic of hospice and end-of-life care with our patients. I find an easy way to bring that up is simply to talk about it. And the earlier we talk about it with our patients, the less discomfort they're going to have talking about it when the time comes.
Another issue that is an obstacle for people being referred to hospice is the feeling on the part of the physician that if they acknowledge that they can't cure this patient, they have failed. And the referral to hospice, in their own mind, feels like they are a failure. Well, I don't see it that way. I try very hard to provide for the patient what I think they need, and I don't feel I gave the patient a fatal illness. If I have someone with a brain tumor that's going to die, I didn't give that person the brain tumor, but I'm going to give them everything they need till they die, and it's not my fault that they died. So I'm going to get them to hospice and engage hospice in the end-of-life care.
It was both my wife and I. The doctor said future or additional treatment will be futile. The tumor's growing. We can't stop it. It's time to call hospice. I refused. Said no. We're gonna continue treatment. And that's when my wife asked me to leave the room for a couple of minutes, and that's when she told the doctor, no, she'd had enough. I came back in, and there's no decision made at that time. My wife and I at that time left the hospital, and we went up to Ann's place, and we spoke to a clinical psychologist. And that was the first time I'd ever been able to talk to my wife about death. We went home, and it took me 2.5 hours to get my wife from the garage up to the bedroom. We waited for the weekend to be over, and Monday morning I spoke to her, and we called hospice Monday morning. And they were in the house within an hour.
It was presented exactly 1 week before he passed. And it was because my husband no longer wanted the visiting nurse to come and insist that he go to the hospital. He didn't want to go to the hospital. He wanted to die at home. He knew that he was dying. I don't think we all knew how close, but he did. And he asked me if he could stay at home. And I said, absolutely. And the nurse said, no, you have to go to the hospital. And I said, no. And he asked her to leave. And when she left, I called his oncologist. And I said, he doesn't want the visiting nurse to come here anymore. I don't know what to do. I'm not taking him to the hospital. He said, it's time to call hospice. And hospice was there within an hour. I called, he gave me the number to call, and within 1 hour, I had the same experience that Neil had. A nurse walked in with wings as big as the moon and helped us right to the end. Neil had that same experience, where she sat down and explained to us what was going to happen. My husband wanted to know what it was like to die. And she explained it as best she could and told him she would make him as comfortable as she could, that they all would. And it was the first time the whole family, all of us, felt that someone was there for us. Someone was going to see us to the end of it. If I had known what hospice had to give, I certainly would have called much, much sooner.
The time when one recommends hospice care is often a challenging one. But what I've found is that many patients and their families have already anticipated this. Most individuals living in today's society are well informed about hospice, or at least about the notion of hospice, end-of-life care. avoidance of respirators, avoidance of heroic measures to keep them alive. Many of them are better informed about living wills, making decisions about how they want the end of their lives to be determined and by whom. So when you introduce the concept of hospice, many patients not necessarily welcome it, but accept it and don't fight you on it.
This is really a situation where patients will hopefully have many more weeks, even months left to live, and we're really just trying to optimize whatever that time is. It is not a case where we are actively intervening to shorten their time. We're not emphasizing the fact that they're dying, we're actually emphasizing the fact that they're very much alive still, and we want to optimize that experience. The emphasis is on living, not dying, certainly.
So when the cancer had, latest recurrence had spread, and he said that he was going on hospice and had decided, his doctor had said there's no more curative treatment, it's time to look at this. It was his decision, so it wasn't something that was presented to the children, or it was basically to him and my mom, and they made the decision. So he made the decision. That was the decision. We weren't, really wasn't open for discussion kind of thing, but explained it and said, here's what it is. He decided to put on the do not resuscitate bracelet. Did realize that could still see his doctor, was still going to his appointments. It was just that there wasn't curative care left. Probably just about 2 months, a little less than 2 months before my father passed, my mom was diagnosed with pancreatic cancer. And we had already been introduced to hospice with my father, so she was already aware that that was a tool in the toolbox should the time come, because that, as anybody who's familiar with it knows, it's a very, very aggressive cancer with not a very high cure rate at this point, but didn't mean we weren't going to fight for it. They didn't come in and take over. Hospice allowed us to do as much or as little as we wanted them to do, or allowed us to do as much as we wanted to do in relation to the care. So when they came in, my father was very adamant, I want to be at home till the end. When that time comes, don't ship me to the hospital. I don't want to go to the 11th floor, as he called it. And hospice enabled us to do that. So we wrote, everyone, my mother took most of the care for my father, but we all, helped out where we could. What was eye-opening to me is that just because you're on hospice doesn't mean you still don't take care of other conditions that you might have, or other things. You just don't throw in the towel. In fact, my mother, while she was on hospice, she was out riding her bike with my brother and her granddaughter. Actually fell off the bike and broke her shoulder on that. Still went to physical therapy, rehabbed her shoulder, and this was, she was on hospice for a few months, knowing when there was no more curative treatment for that, but still took care of all of that. Still, she had a little bit of a dental issue. She went and took care of that, because those are all things that were all comfort-oriented, and they didn't stop. They didn't say, oh, no, you can't do that. It's really, you're just stopping the treatment for the issue that you're going on hospice for. But then we'd be able to call hospice if we needed to and say, okay, what special equipment do we need for this? Or, what can we expect to see next? A question about medication, what we can and can't do. So very, very, very supportive, and they're very, very responsive.
As far as the plan of care for a patient on hospice, what usually happens is the entire family and the patient, if they're able to participate in deciding what the plan of care is going to be for the patient, everybody is involved in that. Hospice is not just for the patient who's in the bed or who's in the wheelchair, it's for the entire family unit, whether it's husband and wife and children or a privately hired aide that takes care of the patient 24/7. They are all involved in the plan of care for the patient and decide where each step is going to go throughout their hospice admission.
What happens when you get hospice is you get not only a palliative care nurse will come in and provide care, but a social worker who specializes in palliative care, and a home health aide that specializes in palliative care, and a chaplain who's non-denominational who can work with your local clergy or somebody in your community with whom you're affiliated with to provide spiritual care at the end of life. And with all of those services, and then the added benefit of having volunteers come into the home, families feel tremendously tremendously supported. They feel like the patient can improve. They can leave the house for the first time in 6 months and actually go to the grocery store, go out to a party, and leave their family member with somebody that they trust. And so having the interdisciplinary team together to provide care allows actually patients to live longer and makes them feel better about the support services that they're getting. Unfortunately, a lot of families and patients don't know that there's a Medicare hospice benefit that's been around for 35 years. And under that Medicare hospice benefit, it's an all-inclusive service. So you get all your medications related to your terminal illness or your comfort measures. You get nursing services covered, palliative care services covered, volunteer services are covered, home health aid services are covered, all your durable and medical equipment that's related to the illness, so the electric bed and the commode and the cane and the overbed table, all of those are part of the all-inclusive Medicare hospice benefit. And in that, families can actually be on a hospice benefit for 6 months, which is 180 days, which is a pretty good amount of time. That doesn't mean on the 6-month mark, if a patient improves or they're about the same in terms of their care, that we discharge them from the program. That's not at all the case. As long as a physician is still willing to certify that a patient's appropriate for hospice, we'll continue with those services. But unfortunately, families don't benefit from the services because most families take hospice services way too late in the length of the illness.
Another part of what I think they need to know is that there is bereavement afterwards, and that tremendous amount of help that you need when it's over with. And that they don't just get up and say, okay, we're done now. We helped you get to the end. It's not the end. It's not the end at all. In many ways, it's just the beginning.
Sometimes when you're out or when you're with family or whatever, you can't be as emotional as you really want to be. And the bereavement group gave me that outlet. Boy, sometimes we all cried together, sometimes we all laughed together, but the emotions did flow through everybody in that group. And we learned that, you know, we're not alone. We're not alone. It happens.
We would go out to dinner, because one of the difficult things when you lose a spouse is going to dinner with your family and there's an empty seat sitting there. And so it was a way to still celebrate your birthday, but with a group of people where there were many empty seats, but we had hearts full of love for each other, that group. We really did. And it all came about through hospice and bereavement. It did. We used to do lots of things together.
Yep. When you go out with family or whatever, you always feel like you're a fifth wheel. You know?
Yeah. Even the friends you had before.
Yeah.
It's
friends you go out to dinner with. One of the worst things are you sit down at a table for 4 and the waiter comes over and takes the other setting away. And
yeah. Yeah.
You just want to get up and walk out. You know, it's. But with the group, we all got along together.
It was
we
great.
all just.
Yeah, it was great.
Yeah.
It was like when someone said, "I know how you feel." You knew they
knew,
but we knew that they knew how you felt.
I think that hospice work is not easy for people to do. And I think that people that come to this kind of work and want to take care of patients who are quite ill and have advanced illness is very difficult for them, for staff. But in any kind of healthcare world or community, as a professional caregiver, we have to first be able to know how to take care of ourselves first. Because if we go into a home and we're really having a bad day, or we've had an issue with our spouse at home before we've gone to work, or before we've gone to our patients' homes, it really does impact the care we provide. So it's really important that before anybody goes in to provide care to patients, that we make sure that we are completely open and that we're able to be there for the family and the patient when they need us. And that's especially important when we do this kind of work every single day. Every single day, our nurses and our clinical staff have a patient that passes away. And so for them and for me, it's really important that they're refueled, that they have a sense of energy, that they have a sense of wholeness, and that they're not feeling stressed out and sad. And for that, one of the things our team does is we have a counselor come in and meet with our team regularly to do debriefing. to do meditation and guided imagery and things that I think many healthcare providers are starting to utilize. And I think we started doing it a few years ago, and it's really now catching on in the medical community. But it's vital to the work we do because we're not machines. You know, we're taking care of people who are dying. And so what's so important is that every day that we're able to, you know, nourish ourselves and give back to each other and work as a team to support each other so that we don't get burnt out and that we are able to provide that kind of care to each other that we provide for the patients and families.
What we want to do is provide them with better care and more appropriate care as they reach. And care in the hospital when you're sick, when you're terminal, is often impersonal and not caring. The care you get from people in your own home with your loved ones around is far more personal. Certainly the way I would want to go, I'd rather go there than a cold hospital room with healthcare professionals who want to help but who I don't know. And I think we as a society have to better educate ourselves about what each of us want as we approach the end of our lives.
I know my wife felt better because, you know, I guess it's a psychological thing that, you know, there's help here. You know, there's someone else besides my husband and, you know, some other people, you know, some friends. There's real-time help here on board for me. So I think there was a lot of psychological thing there with her about that.
And my dad was a World War II 8th Air Force veteran. His very first bombing mission was on Christmas Eve. He had a story where he actually flew that first mission, landed in RAF Air Force Base because they were pretty shot up, and went to midnight mass when he landed there. So it was a very important date for him. And he was like, I'm not going to die before Christmas. I'm not going to ruin people's holidays. And on Christmas Eve, 2 weeks before he died, he went to church with the walker under his own power. To think that just a little over 2 weeks later, we were going to be there for his funeral. But he was able to be empowered to say, I'm going to go this one last time, and I'm going to go there, and sat in the back row, and then, you know, would not, you know, wouldn't go in a wheelchair, went in with his walker. And it's almost a gift that a resource like hospice gave us, because otherwise, what is the option? It's you're in the hospital, you're just there, and they're gonna, you know, I'm sure the nurses are caring and what have you, but it's a cold environment. It's not home, and you know, and that's tough. So I would say, you know, hospice was empowering in our situation, and the same with my mother.
And I think that was the most beautiful thing of all, you know, that he just gradually went into the transition with all of us there, you know. Robin the nurse, my dog, you know, my family, from the youngest grandchild to the oldest, you know, everybody. And he had that. I mean, he was relaxed enough to open his eyes and say goodbye to everyone. That was like wonderful. It was a gift.